Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to sign the attendance record, and also please remember to fill out the program evaluation. And the CME committee is always interested in any ideas that you might have in regards to future topics and future speakers. Today I have the pleasure of introducing Dr. Eduardo Beltroy. Dr. Beltroy is board certified in pediatrics and pediatric gastroenterology, and during his training he was a recipient of several awards. He's had several papers published, and he's previously been here to provide us with another Grand Rounds talk, and he kindly accepted our invitation to return today to discuss reflux. Please join me in welcoming Dr. Beltroy.
Thank you, Dr. Haller, for the kind introduction. Thank you, the Arleys, for the invitation, and thank you all for coming today. It's my pleasure always to come to Mary. Really, it's my second time, and I really enjoyed the first time I was here. Can you all hear me way in the back? Otherwise, I'll move you all forward. Okay, all right. All right, we'll talk about reflux disease of the century. I have no financial disclosures, and I'll tell you why I call it the disease of the century and why we should talk about reflux. There has been an enormous rise in the use of proton pump inhibitors in children, and these numbers are specific for infants. Just between 2000 and 2009, there was an 11-fold increase in new prescriptions for a PPI in infants, and most of them under a year of age. That translated in 2009 to 118 million prescriptions, $13 billion in PPIs. I have a lot of trouble believing that this is because there is more reflux. So I think that reflux is overcalled and overdiagnosed, and these numbers are probably a reflection of that. So I think it's very important that we have a clear understanding about reflux. So today we'll talk about the pathophysiology of GERD and the difference between gastroesophageal reflux, or GERD, and reflux disease, or GERD. We'll understand the natural history of reflux in infants, so you can reassure the parents, review the indications for different tests in the evaluation of reflux, and discuss different treatment options. Now, before I continue, how many pediatricians are in the room? Any pediatricians? All right. Well, I'm a pediatric gastroenterologist, so most of my lecture is focused on children. You may be. Well, we try not to extrapolate findings from the adults into children. You see why, but may do a little more. I want you to differentiate these terms, because there's a lot of confusion about these definitions. Gastroesophageal reflux is the passage of gastric contents into the esophagus. That's about it for reflux. We all have reflux in different amounts. That's a normal physiologic process throughout the day, especially after eating. Regurgitation is the passage of the refluxed gastric contents into the pharynx. It can come out also, out of the mouth. And how do we differentiate regurgitation from vomiting? Vomiting is usually a centrally mediated process with retching, nausea, retrograde contractions in the upper digestive system, and a forceful expulsion of the gastric contents. And reflux disease is when you have reflux and have troublesome symptoms or complications from reflux. And then we'll talk about what troublesome means and troublesome for whom. Do babies have normal stomachs and normal acidity, or are they all premature or preterm? They don't have anything developed yet? Well, we know that the structure of the stomach is completed by 14 or 15 weeks gestation. So the babies are born with a fully developed stomach with all the cells. Okay. Term and premature infants, 24 weeks and older, are able to maintain a basal gastric pH below 4. So since birth, and in a premature baby above 24, you can have a normal acidic pH in the stomach, and that's a protection against pathogens. That's why it's there at birth. However, there is an increase in the acid secretion in the following weeks after birth, and I'll show you a graph that depends more, not so much on the gestational age, but more so on the extrauterine factors, the type of feeding, the time of the feeding, or any other complications that may affect the acid secretion. This is a study done in infants and children, measure the volume and the acid output. And this is the volume in mLs per hour. And you see that this is an adult and this is an infant. Volume-wise, obviously the adult makes a lot more acid. However, if you measure the milliequivalents per kilo per hour, at about 4 months of age, that baby is making the same amount of acid per kilogram per hour. And we'll go back to this. Now, just want to mention that a 3-month-old baby is making about 10 or 11 ounces of gastric acid a day. And a 4-month-old baby, it's probably making about, this would be 1,000, about 35 ounces of gastric acid a day. And that's probably more than the formula the baby's getting. So when they speed up and keep gaining weight, the parents say speed up the whole bottle. You have to reassure them that what comes out is not only formula. Remember that the stomach produces a whole bunch of acids. Okay. So what's the pathophysiology of reflux? In order to have reflux and complications for reflux, you have to break many barriers. It's not as simple as the acid comes back up into the esophagus and that's it. You just have to break that lower esophageal sphincter. No, it's a lot more complicated than that. Our body is designed to protect ourselves from the acid coming back into the esophagus. And going from below up to the mouth, we start with the esophagogastric junction, and there we have 3 barriers. We have the diaphragm that makes a little impingement in the distal esophagus. We have the esophagogastric angle, the angle of His, which is an acute angle. And if you look at a picture, it may look like a flap, but it's not a flap. Yeah, I like to mention that because a lot of pediatricians refer to as the flap is not formed well because you're a baby. That's why they have reflux. It's just an acute angle that looks like flap, but it's not. So that's another barrier for reflux to come back. And then we have the lower esophageal sphincter. So you have to break these 3 barriers to have the acid come back into the esophagus. Then let's say the acid goes back up into the esophagus. There you have the esophageal peristalsis that will push the acid back down, back into the stomach. The esophageal secretions will buffer the acid and also help draining the acid back into the stomach. And the mucosa itself has its own protection with a little bit of mucus, and the epithelium, the cells are together, breaks into the cells, so that's another protection for acid. And lastly, the saliva that you swallow will wash off any residual acid that might have stayed in the esophagus after all these processes worked. So I want to concentrate just a little bit longer on the lower esophageal sphincter because it's blamed for reflux. And so the parents have this idea that the baby's sphincter is not well developed and that's why they have reflux. Well, back in 1971, Cohen and Harris were the ones who introduced this concept of a defective lower esophageal sphincter, LES. They studied 75 patients with or without esophageal symptoms compatible with reflux and plus or minus hiatal hernia. And they stated that symptomatic patients were readily separated from asymptomatic ones by a weaker baseline sphincter strength. From then on, everybody started talking about a hypotonic LES, or not fully developed LES. And that lasted for several years. In 1982, Dodds was blamed with the first description of the phenomenon of the transient LES relaxation as the predominant cause of reflux, and not so much the hypotonic LES. He studied 10 patients with reflux esophagitis and 10 controls with manometric studies and pH probe. And he found that 65% of the episodes of reflux were related to abnormal transient LES relaxations. And only 18% were associated with a low LES resting pressure. So that changed the whole picture. It's not that the LES is not working. It works really well. It's just that it opens up too often and too long in certain patients, enough to give you a prolonged exposure to acid in the esophagus and give you trouble. So it changed the whole thing. However, we pediatricians had done that work already. 2 years prior to that, Werling studied 29 children, 5 days to 2 years of age with symptoms suggestive of reflux, meaning regurgitation, vomiting, irritability. And he found that 54% of the episodes were related to transient increases in the intraabdominal pressure and 34% to the transient LES relaxation. And only 12% of these infants and children had a low basal LES pressure. So a hypotonic sphincter is not, it's actually the least frequent cause of reflux in infants and children. It is well developed, it works well in most of the patients or the children. It's just that it opens up too frequently, too many times and for too long a period. So transient LES relaxations are the main cause of reflux. Okay. Take-home message. What decreases LES pressure? Gastric distension. Every time you eat, your LES pressure will decrease so you can vent the pressure from your stomach. And that's why we burp. And that's why we all have, if I put a pH probe on all of you, I will find reflux. You're not going to find a flat line above pH of 4. Okay, that's a normal physiologic mechanism in children and adults. Now think about a baby who eats every 2 or 3 hours, 4 or 5 or 6 ounces. The stomach gets distended and the LES will relax and they will have regurgitation. Now think about a baby who's is gonna increase his weight 3 times over the first year of life. Try to extrapolate that to yourself. How much you have to eat every time to triple your weight in 1 year? I bet you'll be bloated and vomiting because you'll be very distended. Okay, so you kind of lose that sometimes as pediatricians. Relatively speaking, the amount of food that the baby eats is enormous and frequently. So they have frequent regurgitation. Fat in the duodenum. Fatty meals tend to sit in the stomach for a long time, but when it goes into the duodenum, probably through activation of CCK, not CKK, decreases the pressure on the LES. Smoking, of course, and that's why we recommend our parents not to smoke or quit smoking when they have a baby with reflux. And they'll say, well, I smoke outside, not around the kids, but you still bring the smoke in your clothes. You still smell that smoke. And that could be enough to lower the pressure of the LES and make the reflux worse. Mint, peppermint, can also relax the sphincter. Chocolate, same, and a lot of other hormones and intestinal peptides. What's the prevalence of reflux? How frequent is reflux in children? Suzanne Nelson in 1997 sent out a questionnaire to 948 parents of healthy infants less than 13 months of age and asked them about regurgitation at least once a day, and another group about 4 or more times a day. And she found that 50% of the babies between 0 and 3 months regurgitate at least once a day. 67 at 4 to 6 months, and down to 5 to 10% at 10 to 12 months. And the babies who had 4 or more episodes of regurgitation a day follow the same curve. So it's very frequent in infants, but it gets better. Okay, so that's what we got from these this study, and I'll show you the same study later to talk about something else. She again sent out this questionnaire in older children and see what happened after infancy. So she sent out this questionnaire to all these parents of 3 to 9-year-old children, 10 to 17-year-old children, and she asked the 10 to 17-year-old children themselves to fill out the questionnaire. And this is what she found. She found that heartburn is not very frequent in young children. It is more frequent in the older children and adolescents. Epigastric pain is a major complaint in young children, not so much in the adolescents. And regurgitation was more frequent in younger children, but not so much in the adolescents. However, interestingly, when the adolescents filled out the questionnaires, they reported more frequent symptoms than the parents did. So one has to be more assertive about asking the adolescents and their symptoms. Sometimes they want to hide them because they don't want to come to the doctor. Sometimes they just want to be oppositional to the parents and say a totally different story. So we have to ask them. But just tell us that although these symptoms of heartburn, regurgitation, and pain are less frequent in children than they are in adults, they still happen. Okay. This study done in Japan in 2002, similar to the one done by Nelson, questionnaire at the 1, 4, 7, and 12 months visit healthy infants. 47% at 1 month, 28% at 4 months, and 0 at 12 months. They didn't see the peak between the 4 and 6 months that Nelson saw here in the US, but they still agreed that reflux is very frequent in infants and it gets better by the time they turn 1. So we have a lot of data that supports that reflux gets better no matter what you do. Based on pH studies, we know that infants have more episodes of reflux compared to adults. Not only that, but the episodes of reflux are a little more prolonged. And the percentage of time that the pH is less than 4, which is what we call the reflux index, and one of the things that we look on the pH probe readings, it's higher in infants. So we have different values according to age. So infants have more reflux than older children, and adults have more reflux than children in general, but reflux is still kind of significant in children. Now, there is no study that has yet sampled a general pediatric population using a standard definition of reflux or reflux disease, so we know a little, but we don't know the whole story. We know it's there, not as frequent as adults, but it's there. You have to ask for it. But it's not to the point that you have to spend $13 billion in medication for reflux, probably. All right, so we know what reflux is. We know it's a transient relaxation of the LES. And we know that the baby has a normal stomach and can protect themselves. So what do we know about the natural history of reflux? I told you a little bit already. And we need to know this in order to reassure the parents. Let's go back to this graph. And I want you to focus here. You see between 3 and 4 months of age, the volume triples. The volume of acid per hour triples. And that coincides probably and may explain why there is a peak in the number of infants that have regurgitation between 4 and 6 months of age. So reflux may not be because you have a defective anatomy or any like that, or is it, it may be because of the volume of feedings plus the volume of acid that your stomach is making. So these correlate very nicely to an increased production of acid in the 4 to 6 months of age. So reflux may get worse before it gets better, and that's important to tell the parents because they expect it to go away within a month or so. I personally tell them that most of these babies will outgrow reflux by the time they turn 1, but it may get worse before it gets better. And it's not because the medication, if the patient's on medication is not working, or or is it because they're doing something wrong? It's just because it may be the natural history of reflux to get worse before it gets better. Study done in Australia replicates the same thing. Peak around 3 or 4 months of age, and then the frequency of regurgitation goes down. Okay, numbers are not the same, but the picture is about the same. Okay, so we know that the infants have a lot of reflux, and most of them have physiologic reflux, and all of them will outgrow it. But most of them, by the time they turn 1, maybe 5% will continue a little longer. But we know they have a lot of reflux. What happens after they pass that year of age? Will they continue to have reflux or not? Well, this same study that I showed you the graph and a couple of slides ago, Martin in Australia, follow this group of children until they turn 9 years old. And divided in 2 groups or 3. The ones who had spilling, as he calls it in the article, for more than 90 days out of the first 2 years of life, less than 90 days of spitting up in the first 2 years of life, or no spitting. And he noticed that at 9 years of age, the children who reported heartburn, they were 4.6 times more likely to have heartburn at 9 years of age if they had more than 90 days of spitting up in the first 2 years of life, compared to only 1 here, of course. Now the frequency is still low, 4.5 of all the kids at 9 years of age. However, when you look at vomiting, it's the same thing. They were 2.7, not 27, 2.7 more likely to have vomiting, and 4.7 times more likely to have regurgitation if they had spit up more than 90 days in the first 2 years of life. So there is some indication that if you were a baby with reflux, you may be an older child with reflux. We still don't know. So what happens when you grow up? This very nice study published in 2002, they sent out questionnaires to adults, asking them whether they consider themselves refluxers or non-refluxers, and that's why the yellow is the refluxers, so the green is the non-refluxers. And they asked them about questions of reflux-related symptoms when they were infants or children, and about what age they think they started having trouble. And interestingly, the adults that consider themselves refluxers had more frequent reflux-related symptoms when they were infants and children: spitting up, abdominal pain, heartburn, dysphagia, asthma, underweight, and asthma. They only had 10% of the parents to answer the questionnaire, the same questionnaire, and there was a good correlation between that 10% and their children's response. So there's some data that says that if you had reflux as an infant, you may have reflux as an older child and adult. We don't know if it's the same disease. We don't know if it went away and then came back later, or never went away. It's hard to tell. We don't know. But there's some data that say that you may have trouble as an adult if you had trouble as a baby. How we diagnose reflux? In most of the patients, the healthy infants will be a good history and physical examination. The infants that have trouble with reflux usually present with feeding refusal. That may be the only symptom. Recurrent vomiting or regurgitation, poor weight gain, sometimes irritability, sleep disturbances. And the older child will complain more of abdominal pain and vomiting, maybe some heartburn. The older children and adolescents will complain more of a heartburn and regurgitation. Some may have dysphagia and extraesophageal symptoms. This is the frequency of presenting symptoms in children with reflux. Most of them complain of recurrent abdominal pain. They don't specify whether it's epigastric or generalized abdominal pain. They include everything in one bag. Some heartburn or epigastric. Respiratory symptoms, 22 had regurgitation. So the presentation in children is a little different than in adults, and it depends on the age. Okay, so children are not little adults. You want to know several details when you take a history of an infant and an older child, of course, that you may suspect has reflux. You want to know the amount and the frequency of the feedings to see if the parents are overfeeding. Sometimes the parents try to compensate for the frequent speed up, and they think they're losing all the formula, so they keep feeding him. They're feeding him more and more and more just to make the regurgitation or the vomiting worse. What type of feeding are they using? A concentrated formula or a diluted formula? And that's important, especially in the babies who are not gaining weight. Are they adding any cereal or not to the formula? What position do they feed the baby, or they keep them upright or not? If they're burping well. What's the frequency and amount of vomiting? Is it a painful vomiting? Is the baby irritable with the vomiting before or after? Is it fussy all the time? Is it a forceful vomiting, or is it a passive regurgitation, which can be a lot? It can be a larger volume, but it would be just a passive regurgitation, like a fountain. And I always ask them if it's like the exorcist kind of vomiting, explosive, projectile. That's a different story from a voluminous regurgitation. Premature babies, growth and development, if they had any surgeries, of course, any stresses at home, any significant family history, GI problems or metabolic problems, infantile death or pyloric stenosis, obstructions, etc. And of course, your growth charts and a complete physical examination. Alarm signs that make you think that this is not reflux, it's something else, and you may have to do something different. It's a bilious vomiting. Bilious is never normal. You always think about malrotation. Bilious vomiting, get an upper GI immediately. Or a forceful vomiting. You may see forceful regurgitation, and it may be hard to differentiate between regurgitation and vomiting in normal babies too. The onset of the persistent vomiting was after the 6 months of age. It usually start early, get worse, and then it gets better. It doesn't start that late. So if you start that late, then think about something else. If they have blood in the stools, of course, abdominal distension or tenderness, fever, lethargy, organomegaly, any neurological changes, seizures, microcephaly, etc. All those are red flags in the history examination that make you think that reflux is probably a part of a major problem. It's just one part. Or the vomiting may not be from reflux, it may be from a metabolic disorder. So these are red flags you have to keep in mind in your history and ask for them. All right, so we have a baby that comes, spits up all the time, gaining weight, happy baby. How do we decide if we need to do a test and what kind of test? Well, first we have to ask ourselves 4 questions. Is there a single test that will diagnose reflux? What questions does the test answer? How reproducible or reliable is the test, and how does it guide your management? Are you going to change your management by doing a test? There are several tests that have some place in reflux. The first one is the upper GI. The upper GI is very useful to detect anatomic abnormalities, intestinal malrotation, hiatal hernias, achalasia in older children, strictures, or an external mass pressing on the esophagus. It's a good test for anatomy. It's not a test to definitely diagnose reflux. It's a short test, remember, it just lasts a few minutes. So it has many false positives and negatives. If you have an episode of reflux during an upper GI, doesn't mean it's a pathologic reflux. And if you don't have an episode of reflux during the upper GI, doesn't mean you don't have reflux. It's just you didn't have any during an episode, or you had one postprandial episode during the upper GI. So it's not, this test is not designed to diagnose reflux, which is a very common problem. I see these all the time, referred or diagnosed with reflux based on an upper GI. The upper GI, just to evaluate your anatomy. The baby that comes vomiting bile, get an upper GI. The 6-week-old that you may not have an ultrasound and you suspect pyloric stenosis, get an upper GI. The kid who comes with dysphagia, get an upper GI to see if there's anything there, but not to diagnose reflux. This is a normal upper GI, the stomach, the pylorus, the C-loop, and the duodenum comes up to the antrum of the stomach, and that's a ligament of Treitz. In this baby, there is all the intestine is on one side. That's what you see with my rotation. It doesn't cross over to the other side. This is a baby with pyloric stenosis. And this is a little hydrohernia. So upper GI is very good for anatomical problems. And what happens with the nuclear scans that also get done very frequently? Well, the advantages of the nuclear scan is that it's a non-invasive test. Radiation is not a whole lot. It detects acid or non-acid reflux. It's useful to detect delayed gastric emptying and may detect postprandial aspiration in certain babies. However, it only detects postprandial reflux. If you if you have an episode of reflux 3 hours after the test, you're not going to see any contrast media coming back up. It's not very good for microaspiration. And again, if you have reflux 4 hours after the test and no contrast, but you still aspirated, you're not going to see in the lungs, so it doesn't help you much. It's not a perfect test. There's a lack of a standardized technique to do this. Different hospitals do different things and have different numbers for gastric emptying and all that, so it's very confusing. It has a low sensitivity. Again, you see an episode of reflux doesn't mean it's pathological reflux. Remember that we all have reflux after eating, and these babies are being fed, or children are being fed. So you may have an episode of physiologic reflux. So it doesn't help us much except when you're looking for gastric emptying. Then what about the pH probe, which is called the gold standard for reflux? Well, it's not that perfect of a test either. We will detect the episode of acid reflux. We have an objective measure of that. It may help you determine the temporal association between acid reflux episode and symptoms. And it will tell you how effective is the esophagus in clearing the acid when it comes back, because you look at the duration of the episodes of reflux. And if you do the test in a patient taking medication who is still complaining, he can tell you, yes, they're in a good dose because I don't see any acid coming back up into the esophagus. Or no, I still see a lot of reflux. Then you can make adjustments on the medication. However, it only detects acid reflux. It doesn't detect non-acid reflux. The pH probe lasts only 24 hours, and there is daily variations in reflux. Now we have the Bravo capsule, which can give you data for 48 hours, and occasionally you can try to get it to do a 96 hours or 4 days study, but it's usually 48 hours. But the pH probe will not detect any reflux complications. You can't see whether they have esophagitis or not, or a stricture or something like that. And it's not useful in detecting the association between reflux and apnea in babies unless you combine it with other techniques. This is the Bravo capsule that we tend to use more in older children, usually 4 years and above and older. It's a wireless telemetry device. This is a Tylenol tablet. So it's a small device that we put with a delivery system into the esophagus. We suction the lining of the esophagus into the capsule, and then we pin it. Push a pin into that lining so the capsule stays attached to the distal esophagus, and we get 48 hours worth of reading. The capsule stays there for probably 5 or 7 days, and then comes up naturally. You don't have to retrieve it because they're going to wear this receiver, and this is what we download into the computer, the data in this receiver. It's wireless. As long as they keep it within 3 feet of whatever they're doing, we're fine. So this is what we like to do in older children. Upper endoscopy and biopsies, again, not designed to diagnose reflux unless you have erosive esophagitis. Otherwise, not useful for diagnosing. It will help you to determine strictures, erosive esophagitis, eosinophilic esophagitis that can mimic reflux in infants and older children. And Barrett's esophagus. Barrett's esophagus is not as frequent in children as it is in adults. We do see it in kids that have neurological impairments or esophageal atresia after repair, but we don't see it that frequently. It will help you diagnose any eosinophilic esophagitis, which is in the rise and can mimic reflux, but not to diagnose reflux itself. This is esophagitis, but it can be from vomiting a lot and not necessarily reflux. This is an area of a stricture. This is a hiatal hernia, and this is eosinophilic esophagitis with trachealization of the esophagus. Looks like a trachea. Then we have impedance. When impedance came, we thought it was the perfect test to do for reflux. We didn't have to do anything else. Well, it's good because it detects acid, weakly acid, and non-acid reflux. All of the episodes, and gas. Any liquid and gas that comes back into the esophagus is measured by impedance, so you can detect whether it's a gas bolus or a liquid bolus in reflux. We use it along with pH these days. So the same catheter has the impedance and the pH sensor. It detects brief episodes compared to the pH studies that are a little longer episodes. Have to be a long episode to be able to be detected. And it's better for studying respiratory symptoms associated with reflux. Better yet if you do it with a polysomnographic study, because then you can put it all together, especially in infants with that. However, the normal values in pediatric age groups are not yet defined, so there's a lot of controversy. It's used a lot in research, and there's several centers that do impedance. We don't at this stage. It takes a while. It takes some time to interpret the tracings, because you have to decide whether it's a gas or a liquid bolus, whether it's acidic or non-acidic, and whether it's correlation with the symptoms or not. It's a little more complicated than reading a pH probe. And yes, we have a good study, but we don't have a good therapy for non-acid reflux, short of doing an Nissen fundoplication. There's some studies using baclofen to help with a non-acid reflux. However, the data is still not, it's not very strong, and the non-acid reflux not going to respond to a PPI. So short of doing a fundoplication, there's very little you can do about non-acid reflux, but just to know that it's there. Okay. Supraesophageal symptoms of reflux, I'm not going to talk about this because this is a talk in itself. We can spend hours discussing all these topics, but there are all these symptoms that have been associated with reflux. And I say associated, not necessarily proven to be a cause and effect. Okay, but that's another topic that we can discuss at another time. So how do you treat reflux? Well, you want to control the symptoms quickly. You want to keep the patient asymptomatic for a long period of time. You want to heal esophagitis if they had esophagitis, and you want to prevent any complications from reflux. So in babies, what we do is we try to spend time explaining to the parents the nature of reflux, that half of the babies at this age have reflux. It may get worse before it gets better, but it will get better eventually. It's just a matter of time. And this is especially for the happy speeders, which is the baby who's growing well, always happy, playful, but spits up many times a day. Then you may want to try to thicken the formula with rice cereal, and you can use 1, 2, or 3 teaspoons per ounce, or tablespoons per ounce, or probably anything more than that will be not only too many calories added, but also too thick. People tend to cut the nipple open when they thicken the feeds, and that can be a problem because every suck and every feeding will have a different force applied by the baby to get that formula out of the bottle. And if you have a big open nipple, they can get a big bolus of formula and choke on it. So the recommendation is not necessarily to cut open the nipple. Now the other thing you may do is just to try a different nipple with different flow. You can change the nipple to a different flow, and that may help. Now there are pre-thickened formulas that have shown to be effective in decreasing regurgitation, not reflux, because when you put a pH probe, that baby will still have reflux episodes into the esophagus. It's just that you're not going to see it. The parents will feel that better. Okay, so you can use a pre-thickened formula. You may want to try a formula change. There is some data to support a trial of a protein hydrolysate formula for 2 to 4 weeks, because some of the babies that have milk protein allergy can present just like reflux, and you may not be able to determine which one is what. So you may want to consider to change the formula, and also positioning. Keep the baby upright after feedings. It has been shown many years ago that the best position for reflux is supine position. This is way before the back to sleep. So we still recommend to put the babies on their back to sleep. But if they're awake, you put them on their belly. That's the best position for reflux. And use of antacid, you have to be very cautious about it. Non-pharmacologic therapy, as we talked about, normalize the feeding volume and frequency. Some of these babies are being overfed, so you change that. Thicken feed position and hypoallergenic formula. For older children, avoid large meals. Do not lay down immediately after eating, at least 2 hours between the last meal and going down to bed. Lose weight if they are overweight or obese. Avoid things that can decrease the pressure and lower esophageal sphincter, like mint, caffeine, chocolate, big fatty meals like we mentioned earlier in the lecture. And eliminate exposure to smoke. None of that works, then we have some medications. We have Prokinetics, we have H2 receptors antagonists or H2 blockers, as we know them, and proton pump inhibitors, or PPIs. The Prokinetics, we have bethanical, metoclopramide, domperidone, and erythromycin. Bethanical, there's only one randomized controlled trial in children that didn't show any significant effect, and is not approved for treatment of reflux in children. Metoclopramide, there's 1 out of 6 randomized controlled studies that show some improvement in esophageal pH, but only improvement in 1 out of 4 of the randomized controlled trials. But it has a high incidence of adverse events, and the one that I worry the most about is tardive dyskinesia, which may not be reversible. So I personally don't use metoclopramide or Reglan to treat reflux, and it's not approved for reflux in children. It is approved for reflux in adults, but not in children. Domperidone is not approved in the US for any indication whatsoever. Does it work? Well, it seems to work fairly well, but you can't get it here unless you buy it in Canada. And very few physicians will give you a prescription to get this medication somewhere else and use it. Certainly not in children. Erythromycin, again, is not approved for treatment of reflux in children. We do use it. I don't use it personally because I think it's a little complicated to dose it 3 or 4 times a day, and the benefit is not clear, so I don't use it very much. Occasionally I do. The H2 blockers, we tend to use these more frequently. The advantages of using an H2 blocker, which is ranitidine or nizatidine, the only 2 approved for use in children. It's effective in treating erosive esophagitis. That has been proven. It's a good medication. It's cheap, and there is no need to be given before meals. You can give it with the meal, so you can put it in the baby's bottle. However, the patient may develop tachyphylaxis after a few doses or a month or 2. You may need to go up on the dose, although sometimes going up on the dose may not help, and you may need to change medications. And also, they test really bad. So most of the babies take it well, but some just spit it out completely every time. What are the caveats about using an H2 blocker? There's some data out there that says that if you use it in low birth weight or premature infants, there is an increased risk of necrotizing enterocolitis. So I think most of the newborn nurseries and NICUs are probably shying away from using this in premature babies. Term babies, probably they'll use it without any other complications, but premature or low birth weight, I think they're trying not to use this medication. Side effects: abdominal pain, constipation, diarrhea, nausea, vomiting. We've heard cases, we've heard parents come and say, we started him on ranitidine and he got worse. And he might have gotten abdominal pain as a side effect. Now, it is true. Now, some doctors say, well, that's impossible. Well, it can happen. There are babies who will develop the abdominal pain. I have seen babies with constipation and also diarrhea. Then the PPIs, or proton pump inhibitors. Well, the advantages of using these PPIs, and by the way, there's only 4 PPIs approved for use in children. And we'll mention that later. It's a better medication for healing erosive esophagitis than the H2 blockers. They both work well, but this is better. It's only you can give it only once a day, so it's easy to do. The H2 blockers, you have to give it at least twice a day, and in infants you may need to give it 3 times a day because they may be faster metabolizers of H2 blockers, and you may need a dose in the middle. So 2 to 3 times a day versus once a day. Sometimes you need twice, but usually once a day is enough. You can open the capsule, and if they can't swallow the capsule, you can open it and sprinkle it in applesauce, and that'll be fine. But it's an expensive medication, like we saw in the first few slides. What are the caveats of using a PPI for a long time? Well, we think that PPI is probably safe to use it for a short period of time in infants and children. However, there's data coming out all the time that it may not be as safe as we think if you use it for a long time. There seems to be an increased risk of Clostridium difficile infections, along with respiratory infections and community-acquired pneumonia and acute gastroenteritis. It has been associated, although not clearly, with fractures in older adults. There have been cases described of hypomagnesemia that require not only stopping the medication, but give them magnesium to revert that side effect. There's also a concern about eventually increasing the risk of gastric carcinoma because of increased gastrin levels. There are certainly people that develop fundic gland polyps in the stomach from a chronic PPI use, which are usually benign, but there's still a lot that we don't know about using PPIs chronically in children. We're learning some from the adults, but we still don't know a lot. So you have to be cautious when you want to decide to use a PPI in children. Side effects of PPI very similar to the H2 blocker: abdominal pain, headaches. I've seen the abdominal pain and constipation, but you may have diarrhea, nausea, and vomiting too, worsening nausea and vomiting. Only 4 PPIs approved for use in children: omeprazole, lansoprazole, esomeprazole, and pantoprazole. None of them are approved in infants under a year of age. We use it a lot, and I show you the statistics. So a significant increase in the prescriptions for infants PPIs. None of them are approved. Now, we in pediatrics use a lot of off-label medications, but now the companies are obligated to do studies in children. So we may have more information later, but so far there have been a randomized control trial in each of these 4, and none of them showed an effectiveness. For example, they tried omeprazole in infants with reflux symptoms, irritability, crying specifically. And they saw in these 2 groups, 15 infants that took omeprazole and 15 that took placebo for 2 weeks. And this is the reflux index, what we talked about. This is the percentage of time that the pH is less than 4 in the esophagus when you do a pH probe study. Omeprazole was very effective in decreasing the acid in the stomach and decreasing the acid reflux into the esophagus compared to placebo. However, when they looked at the crying time and the fussiness of the babies, no change between placebo and omeprazole. So we know it works well to decrease the acid, works well to heal esophagitis, but doesn't work in the fussiness and crying in the babies. They may be crying for something else and not reflux, or maybe they were not treated long enough. There's still some questions. So they tried with lansoprazole. Same story. 54% in the lansoprazole group and 54% in the placebo group. No change in symptoms. The same percentage of patients discontinued medication because they were not working, either placebo or lansoprazole. Interestingly, improvement was about the same in each group. So the other two also had the esomeprazole and pantoprazole had similar studies. None of them showed any efficacy on decreasing symptoms. They're good to clear the acid, but there's no correlation between clearing the acid and improvement on the symptoms. So these babies may be crying something else. Maybe the volume of the feeding, maybe a normal developmental problem, because there is a crying curve, just like there is a growth and weight, height, and head circumference growth curve. The same for crying, and the babies who are at the top of the curve, and they're probably ones that we see. So we want to have a medication that is easy to administer, convenient and simple dosing, good tasting. We worry about that in pediatrics. Rapid symptom resolution and minimal side effects. We still don't have a medication. PPI is very close, but like I showed you, it's not approved. They're not approved for infants. Empiric pharmacological therapy used in adults very frequently. There's no studies in children that say that this is effective. Again, we go a lot by reported symptoms. Remember that it'll probably be until they turn 8 or 9 before they can tell you what they feel, what kind of symptoms they have. So it is not only somebody else reporting the symptom, the parent in this case, it's just there is a lot of subjectivity. So you are treating the symptoms reported by the parents. So a lot of these symptoms may not be related to reflux. We do empiric therapy at times, but there's really no support. So in conclusion, pediatric reflux is a common condition. It's not as common as it is in adults, but it is common in children, and we see a lot of those in our clinic. Most reflux episodes are caused by abnormal transient LES relaxation and not by an abnormal LES pressure. The presentation of reflux varies according to the age. It's not the same in infants as it is in children as it is in adults. Okay, so you have to look for those symptoms. Reflux may get worse before it gets better, but it will eventually get better in almost all the babies. So we have to reassure our parents that this is likely to be just a physiologic developmental issue. There's not a single test to diagnose reflux. You have to know what you're asking when you order a test so you can interpret the result. And not everybody with reflux needs a test. And there is pharmacological therapy. There are medications available to use in children, but you should use them with caution. There's some people who say that using PPIs in infants is like doing an experiment where the N is 1, there's no consent sign, and there's no approval by the ethics committee. So some people talk about that. You should be very, very cautious about using PPIs in infants. If you are going to use PPI in infants or children, just like in adults, try to use the lowest dose necessary. Usually once a day works well You rarely have to go to twice a day. If you're going to twice a day, you have to think that it may be something else giving the symptoms. Because in all the studies, the once a day dosing is usually enough. There are some children that will need twice a day because they may be fast metabolizers of a PPI, but usually once a day. So try to use the lowest dose necessary to control the symptoms and for the shorter period of time. All right, well, thank you very much for your attention, and I didn't cover a lot of things, but I hope you have a lot of questions. Any questions? Yes.
Breastfed versus formula fed in reflux disease. You know, gastric distension.
Yes.
Stop
well,
overfeeding.
You know, if you read all the data, is conflicting. Some studies say that babies that breast feed have less reflux because breast milk tends to drain from the stomach faster than the formula. But there are other studies that don't see that. Some people and some studies say that whey-based formulas produce less regurgitation because, again, any whey-based formula will drain faster from the stomach. Casein tends to sit longer in the stomach and may have more reflux. But it's still very conflicting. We do use some whey-based formulas sometimes. And in some kids will work better and in some others don't. So it's still very conflicting.
I'm wondering if you or others in your practice have noticed a correlation between the baclofen pump in children with spasticity and an exacerbation of their reflux symptoms.
That's a very good question, and I really don't know the data. We don't have very many patients on baclofen pumps in our GI clinic, and I don't know the data really.
Excuse me, maybe I missed this, but in your thing with your study with was it a Japanese study that had no 4 or 6 months symptomatic episode? What was the difference there? Did I miss that, or did you see
The Japanese study
that did not have the 4 to 6 month?
Yeah, it didn't have that, and they speculated maybe because of the diet, maybe they're using different, or maybe the approach of the mother, or a cultural thing, or different formulas, but they don't have an explanation for that.
So they didn't go into the diet?
No. They speculated maybe cultural, maybe a cultural thing, but they don't specify why. They don't say why they think this. Any other questions? Yes. It's very, very hard. So that's why I say that to diagnose reflux disease, you're talking about troublesome symptoms. It is very difficult under the age of 8 to talk about troublesome symptoms first, because the infant or the child is not going to be able to tell you. Even more, you have the subjectivity of a second reporter, which is the parent or the caregiver. That they cry doesn't mean they're crying because of reflux. That they cry doesn't mean they're crying because of esophagitis. There is no correlation between symptoms and esophagitis or pH probe findings that has been studied and has shown that just because they cry doesn't mean it's reflux. Now, the parents go out and read on the internet and everything. That's why I called it the disease of the century. Because the parents come to the pediatrician saying, he cries all the time, doesn't want to eat, he must have reflux because he spits up. But we know he has reflux because he spits up. That doesn't mean that the crying is from reflux. You know, we're good at controlling the acid with the PPIs, but the symptom didn't go away. There is a normal crying curve, so, and I always mention that to the parents. Crying is a normal part of physiologic development, neurological development of a child. So you can't convince them, you can try first the lifestyle changes. If not, maybe you can try an H2 blocker. But if you try something, it has to be for a short period of time. There's no change, then stop it. Now, you're going to be trying one thing, and then another thing, and then the next thing. By the time they turn 5 or 6 months of age, they're sitting up and eating solids, reflux is already better. And in some babies, will get better even before that. So they'll tell you, see, it's the medication that you gave me. He did have reflux, or she did have reflux, but it can be just a natural response. So it's, we cannot tell from crying that it's reflux or esophagitis.
Moms who've been using it for lactation, do you have concerns specifically for those infants of breastfed moms using it?
Well, the FDA released a warning clearly saying that there is a rise on using domperidone for these. It's not indicated for that. It's not indicated in the US for anything. So they shouldn't use it. I have not seen, well, maybe I didn't ask, but I can't remember a lactating mother that told me that they're using domperidone. How will that affect the baby? We don't know. Now, it is used in Europe and South America, and it tends to work fairly well, I would say. But again, there's no data. Any other questions? All right, well, thank you very much for your attention.